Hello, everyone, and welcome to the first webinar from Spectrum Cancer in collaboration with Quantum Surgical. My name is Raj Narayanan. I'm going to be moderating this webinar. I'm an interventional oncologist from the Miami Cancer Institute, and today we're going to be talking about robotic guided percutaneous ablations. We're very excited to bring this webinar to you, and I'm joined today by an esteemed international faculty. We have Professor Thierry Debert from Gustave Roussy, France, Professor Laurent Milot, also from France, Professor Arsalan, who's the chairman at Rush University in Chicago, Professor Pedu from King's in the UK, and Professor Berman from UC San Diego. We're going to be discussing all of their different levels of experience using robotics in their image-guided ablation program. And we're very excited to have Professor DeBear with us, who was instrumental in having this technology move from bench to bedside. Thierry, welcome.
Hello, Raj. Thank you for having me in this webinar.
Thank you for joining us, Terry. We all know that you were very involved with the introduction of this technology and also with the early stages where you performed some of the bench experiments. And can you describe to us the journey of bringing this technology from bench to the clinical practice?
Yeah, as you said, bench experiment is very important to start before clinical practice. I'm talking of bench experiment. I'm talking about animal experiment as well. And then we work a lot with people from quantum surgical, both on those experiments, as well as the ergonomy of the system in the CT suite, how to place the system, how to use the system, which are, of course, a very important point. I think when I met quantum surgical, the core of the system was already ready, but we had to customize some small stuff, what we will call details, in fact, which are very important to the users to be kind of user-friendly. Another important thing about bench experiment that even if it's a short learning curve, if it's easy to use, I think there is a workflow, there is steps to know, and bench is probably the best place to learn how to use the system and to learn the workflow. And I think that even it's very important that every new comer to the system can practice on bench experiments. You will make your first clinical case very easy.
Thank you very much for that. And it's great that you brought the workflow into the discussion, and we can segue to that. As many of us who've been performing image-guided ablations for many years, we've been using the CT console or our PAC systems to plan our image-guided ablations. Professor Milo, as someone who's also been involved using both ablation planning before the robotics and after robotics, can you describe how the workflow changed in your practice?
Yes, hi everyone, and thank you, Raj, for having me today. Yes, that's a great question. Actually, we had a little bit of a different practice, I think, compared to many other people, because we were very ultrasound savvy people. Like we were really trained with ultrasound, using CT as more of a kind of a system to do the kind of fusion, but we are using ultrasound guide ourselves. So in our practice, it has been a lot of changes because we had also generations. So we had people which were only ultrasound and more junior people which are very CT savvy. And I'll be honest with you, something I really enjoy with the Epion system was to be able to get the same type of angle you will get with ultrasound, those very steep angles, and do the same thing. So for us, it has been one of the big things was to be able to replicate this type of very difficult approaches and to share. Talking about workflow itself, of course, a lot of changes because we started to really plan more. To be honest with you, we are very organic in the way we are treating. So, you see the lesion, you put your needle, you destroy, you look at your casket, you're happy, but you never really look at margin. And we didn't really think as much as we do now, as we started to do, looking at, how is the ablation going to be in the end? So I would say for us, maybe, it started a little bit slow, and I will really say to newcomers, don't be afraid of that. That's normal. You'll spend a time, on your console. But then as you move slowly, you'll get more comfortable, and then you'll be able to speed up your caseload like really increasingly. But for us, I would say really the big thing has been to include CT not just as a backup system, but that's our main workhorse. And for us, that's been one of the big game changer. And for that, really, I think the Appian system will be really beneficial. And there's no question we will never come back to the way we were doing stuff before. No
So you've
question.
seen a kind of a transition or more incorporation of CT into your ablation practice. Dr. Berman is somebody who kind of started with this technology around the same timeline as us in Miami. How did the workflow patterns evolve for you in your practice?
Yeah, and again, thank you, as the others have said, for having us discuss today. As Dr. Milo has said, we also tried to use ultrasound as much as we could. And any lesion we thought was going to be very difficult for us to see under ultrasound, maybe at the hepatic dome, or right near the base of the heart or something, we may have shied away from doing ablation for those patients. And so, having the ability to do very steep angles using CT guidance, which is quite difficult to do by hand, has really helped us grow our practice in that regard. But to that end, again, the workflow is a little bit different. Again, you started with placing a needle and then looking on the CT scan, was the traditional workflow. Now we get a CT scan, then go to the Epione console, and then go back to the CT scan afterwards. Has been a little bit of a change where now you have kind of two areas of where you're looking at the scans, being the big workflow change for us.
Absolutely. Professor Pedro, as somebody in the UK, how is your workflow pattern after introduction of Epion?
Thanks, Raj. Yeah, and again, pleased to be here and pleased to join this faculty. We are very much at a very early stage right now. So we've done first 15 patients with the robot. And I think that we're still in the process of adapting the robot into our practice. For somebody like us whom we do roughly about 30 ablations annually, most of them are microwave, about a quarter of them are IREs. It's a big change for us because there's a lot of things which I think as a beginner you need to understand, which we probably didn't quite understand when we first started. Secondly, the workflow needs to change significantly. We've been using, very much the Siemens iSequence where we tend to place the needles with the CT fluoro, and then off we go with the ablation. So that is a complete mindset change where we don't need to do that anymore. We don't need to put LEDs on in the scanner anymore. You just need to do everything on the machine, on the robot, and the robot does most of the planning for you. And essentially, once you park the robot, once you get the robot to the place where you want, you just go in, put your scrubs on and put your gloves on, and then just a matter of fact, you're just putting the needles in. So it's a complete mindset change from having to push the needles, all of cells. It's completely different. So we're still adapting to that. I mean, although we've done 15 cases, there are 5 of us, doing it. So I'm the one who's done most. I've done 5 of those, and I'm just about getting to the grips of it. So I still think I probably need another few more, probably another 5 or 6 cases before I can completely go, solo without any support. And I can see a huge benefit with this, in terms of standardizing the practice, in terms of reducing the number of needle punctures to the capsule, and also reducing the amount of time, particularly for multiple needles. When you're placing IRE, when you're doing an IRE where you have to put multiple needles in various angles, and that can be a major challenge if you're doing freehand. And certainly with a robot, that takes that complexity out of the equation, makes it much more simpler to use. So I think there's a lot of learning curve still to be gained for us before we can get completely proficient with the machine. But I can see the benefits already as I plan.
Segueing to learning curve, Bulent, you have a diverse ablation practice at Rush. I know you perform microwave, cryo, and IRE. And for a diverse practice like that, with an established ablation program, what was the learning curve like when you introduced a Epion into your ablation practice?
It was actually a lot easier than I thought. I mean, we are also an academic program. We have a lot of residents, and we're a residency-based program. So one dilemma for me was, how much do you let them do because they need to learn, and how much. And in some of these complicated ablations, that kind of is a little issue. A robot took that away.
Yeah.
You do the planning. All someone has to do is just push the button, and now I let them push the needle or the probe forward, after you plan everything. We check it once, and then on the second one, you're in the lesion. I guess, once we're kind of a late adapter. We only have done like 4 or 5 cases. I have done two myself, but I can see that it's gonna be like a single push, like you're doing most of the times right now. And it's made things a lot easier, less stressful for us. And it's also opened up the more complicated, should we do it, etc. kind of cases, even biopsies now. We had a couple in our last tumor board that I would have been reluctant. Hey, we can try. It's right at the dome, 15 centimeter, etc. It's like hit or miss. We're definitely going after all those lesions right now.
Great point. I mean, we did two yesterday with two lesions in each patient, all four were either dome or critical locations, and our trainees were able to nail it. Dr. Berman, you have a residency program and you have trainees with you. How has their experience been taking to something, a new technology like this?
The benefit for them is we've already kind of gone over our initial learning curve as faculty. And so now that you have new residents coming through, this is all they're learning how to do. And so for them, this is just how you do an ablation, which is nice. And maybe 10, 15 years from now, we'll lament the day that our residents don't know how to do an ultrasound guided ablation.
Yeah.
But it's the same logic I use for ultrasound guided arterial access for angiography. My mentors were making fun of me for not knowing how to do it by palpation. But I'll never go back to not using ultrasound for my arterial access, just like I won't ever go back to not using a robot for ablations.
Yes. Terry, when you introduced this into your practice, did the rest of your colleagues take to it, or was it initially a challenge? Because a lot of times, including me, before I had my long conversation with you, the question that an IR always asks is, why would I need a robot for performing an ablation, which I'm trained to do? How did that play out in your practice?
Well, that's an interesting question because when we start with, I was kind of the only one using robots. But as let's say the first 10 cases, and then people get interested, intrigued. And if we look at what we have done today, over 100 cases, we have many users. All senior staff have been doing more or less the same number of cases. We start to let the residents do the case with the robot alone. I went back to the hospital last week. I was very happy to be back. And I was just coaching a resident that do the lung ablation with the robot by himself. So I was just giving questions. But I really want to make a point that there is a short learning curve, but it's very important to know about the small tricks that will make your ablation successful. You have really to respect what is the workflow. You have to know that you have to insert the skin. You have to make a small incision to the skin before inserting the needle. You have to know that you have to place the needle holder as close to the skin before you start. Because most of the case where we are not very happy with the result, we just realize that, oh, the needle holder was a bit far away, the needle was bent. So all those small tricks are very important. And I will say lucky for the next comer, the next user. All of us in this panel, we have experimented all those small tricks that really improves the outcome of the technique. So it's not because there is no learning curve that anybody can do it without doing it before on a bench top and learning all those small tricks.
Great points. One of the things I've noticed in our practice, we are now into our third trainee class, and I see these trainees of ours have taken to this technology, almost like naturally. They don't seem to have any issue with it and with the software or how to navigate it. Laurent, do you have trainees in your program, and how has your experience been with them?
Yes, so we have a large training program as well, like as all of you guys. So we are one of the largest in France because we are a big city and it's only one kind of training program compared to Paris, which is way bigger, but a lot of different sub areas. So we have a very large training program. So yeah, it's interesting this question. So for us, I would say the trainees they love it. Actually, they love it a little bit too much. So they are a little bit too enthusiastic sometimes, and we do, and we'll go over that I'm sure later. But we start to do very difficult cases. Like I think some stuff we would never have done before. And I have to say to them, okay, you know what? I know the process is easy, but the case is still very dangerous. So you won't do this one. You are not just gonna do it at all. But conversely, I had a trainee recently. He did like a 3 needle ablation microwave complex lesion by himself. I just look at him. Interestingly, he struggled to do the because we did the biopsy with ultrasound first, and he was not able to hit the lesion.
Yeah.
Okay, but then he did a three microwave ablation placement, beautiful,
Yeah.
destroyed a large 4 centimeter lesion. So I was struggling actually with this information. What am I going to do with that? Like the guy can get a large lesion with ultrasound guidance, but he can do a 3 needle ablation. So I think, it's kind of a really good for them. But I also want to echo a little bit what Zach Berman was saying before. I think we have to be a little bit careful sometimes just to make sure they still get some ground, abilities. They're
Of
not
course.
going to get the robot all the time. So I think that's been the trade-off. But I completely agree. They learn so quickly. Actually, they have no inherent bias, of how they were doing things before. So I feel that they really adopt the technology extremely quickly, and they're really good with it, no question.
That's great. I know in the US, we are mostly using Epion for abdominal cases, and Europe has been a little ahead, and uh, there's work going on in lung and also the study for bone. Thierry, can you talk to us about the EpiBone study, which started over there? And my understanding is now we're bringing it to the US too.
Yeah, I mean, that's same story. Before we go to the bone, we went back to the benchtop, we went back to animals, and we define how to use the system in the bone, which is slightly different of the way you're going to use it in the abdomen. I can show you that with a few images if you want. And really, um, there is a different way to use it in the bone. Same thing. If you don't know the tricks, if you don't know the workflow, you will not be accurate, you will not be efficient. So far, the EpiBone study is finished for enrollment. So soon the result will be published. We already published the result from the animal experiments, where we were very close to the target. The slight difference in the bone is first that you have to enter the cortical bone first, and then you have to check with CT. Because in the bone, if you get the wrong direction, there is no way to correct your needle trajectory afterwards. So you have to correct it as soon as you enter the cortical bone. And with Epion, we develop what we call the recatch. So you can recatch your needle, you can realign your needle on the correct trajectory for a second chance. Of course, it's not always needed because if you're on trajectory, you have nothing to do, but you have to slightly change your way to work. Otherwise, I think the bone is an ideal landscape to do that because there is no respiratory motions. It's fixed bone, so it's easy. And once again, I mean, you can argue that you have cone beam CT. When you have to do cases with a high angulation in the z-axis, we all know that you cannot bring on cone beam CT on the bull eyes view, and that will be complicated for you, where, of course, the robot, you can send it in the bull eye view, I would say nearly anywhere. So added value is really when you do those ischiatic access, those very ascendant, descendant trajectory.
They're great points, and I also think it's great that it is being studied in a trial first before being brought into clinical practice. So, uh, you know, that's a great thing. So, Dr. Arslan, you are chairman in your IR department. Congratulations on that, on establishing the an independent IR department. But how did you convince your hospital administration to invest in a technology like Epion, bringing robotics into your practice?
Yeah, I mean, that was obviously a challenge for most institutions, right? There's no dedicated reimbursement yet, and then you have to kind of justify it one way or the other. And then we discuss with them how the safety implications are, and then potential additional cases that we kind of would either be hesitant or not do. And also, robotics in surgery has made huge strides. That they've been marketing it in a lot of institutions, and it's kind of well accepted right now. The way that I propose to them is say this is the beginning of robotics and image guided therapy, and this we're just at the first. Do you want to be first, take this over, and become the kind of one of the eminent centers of this, or do you want to kind of follow the crowd? And so that was that pitch out thought. And then we're doing pretty much what we told them. We already got some referrals for this. We're using it in our marketing, and we're getting cases just for this purpose. And then within the city also, if we have, we mentioned in our NGO club meetings, etc., if somebody has a case that they're reluctant to do, they're happy to connect to us. So it definitely had an impact. I think it's definitely going to pay for itself and then do a lot more in terms of financial. It also allows us to elevate the cases to our patients that otherwise would not be as safe or as efficient. And at the same time, being a training program, as I mentioned earlier, all the kind of the boxes are fitting into the place. That's how I proposed to them, and they accepted. They didn't give me too much of a hard time, and we're actually following the plan that we laid out for them.
That's great. Dr. Berman, I mean, you started earlier than Dr. Arslan. With what you've learned over the use of the time of using the Epion system, what advice would you give to somebody new, and what should they be highlighting to their administration to bring this technology in?
Yeah, I think the first thing is you can't rely too much on your first 4, 5, 6 cases to determine how the rest of your experience with the robot is going to go. There is a learning curve. It is quite steep, and we've looked at that. But once you hit your kind of plateau, which is actually quite quick, the procedures end up being roughly about the same time that you were using before the robot. And more importantly, you're now taking on more complex cases than you would be able to do before. So, traditionally, if someone had 5, 6 lesions, we may have not done that in one treatment session. Now that's a lot easier for us to do in a treatment session. And then if there's a dome lesion that we may have not offered therapy to before, we are now offering therapy. And once you get over that initial learning curve, you're able to offer the same therapy even for these complex cases in the same time footprint that your other ablation cases would take. Discussing with your administration so that everyone knows, before going in, don't look at your first 3 cases and say, oh, this is, taking twice as long. We have to get rid of this thing. It really does catch up in the end, and you end up saving time on the back end once you get experience with it.
Oh, I think that is key to stick to a new technology to see it through. A lot of times we might lack the patience to stick with the new disruptive technology and come to conclusions really fast. Prav, in the UK, how did you manage to convince your administration, and what advice do you have for your peers there?
Yeah, I think that's probably going to be the challenge for any institution. It's just because we have a tariff here for microwave, and that's a fixed tariff. So you have to figure in hospital admission, the bed, the whole thing, including the microwave needles, etc. within that. So clearly, obviously, a robot will bring an added cost to that. So the way I went around with speaking to the procurement and the management is that one, we're going to standardize the procedure, which means that we're going to produce more consistent results. 2, we're going to reduce the number of patients who are going to return for a repeat ablation for incomplete ablations. We looked at our practice about, particularly in colorectal, there's a high rate of incomplete ablations. So I would probably say something in the lines of, maybe about 10 to 15% repeat ablations. And I think with the Epion, with the ability to, to place multiple needles, particularly for RE and also for microwave, and also the ability to compare your needle placement with the original scan, just to ensure that you have, in fact, you have managed to, get the treatment you want, and also having the post-ablation confirmation software there is a good reason to believe that you're going to get much more complete ablations and reduce the number of repeat ablations that you have to do. So that's an added benefit, one. And also, last but not the least, is the patient safety. I mean, all the manager wants to hear these words, the patient safety and money saving. The patient safety aspect of that is you're not puncturing the capsule 3 to 4 times to get to a difficult lesion, a complex lesion in the dome. And you tend to you often use a single pass with the robot, so that's a big advantage. So that reduces the amount of capsular pain afterwards, potentially in reducing the amount of time the patient might stay in the hospital. So you bundle all of these together, and you say, in future, once you get really proficient with the machine, and once you are very quick with your workflow, you can do more number of patients. You can reduce the number of repeat ablations. 3, you can reduce the complication rates, and also potentially overall patient experience and outcomes. So all of that put together, we bundled into them, and we managed to convince them. And they said, "Why don't you try 30 patients first, and then tell us what you think, and then we'll think about the future aspects." So that's where we are at the moment. Yeah.
No, all great points. I think that all of that is important. You also touched on something. When we think about robotic guided ablations, the idea is usually people think about the robot being able to help you place the needle, but all the other enhancement that come with it make it a complete package. For example, the overlay to check on the ablation margins. The days of us just looking at contrast enhancement or lack of after the ablation is going to definitely change, and this is a step in that direction. Laurent, in your practice, I know you also you use different technologies. And have you seen with the introduction of Epion that you're able to do more complicated cases with a higher level of confidence?
Yes, so thank you for the question. Actually, I would say among all of you, I think we likely are the people who made the biggest jump with it. Again, for many reasons, I won't go into some of those reasons, but actually, even looking at margins, like we look at, I won't say the number we had before Epion because I don't want to say it, but it was not great. We reduced by something like 2.5% our recurrence rate. So that by itself has been a major changes. One of the big reasons has been better planning, not just putting needle in, but like planning how we put needle, multi-needle as well. Definitely has been a big game changer for us. But I agree, on top of, I would say, improving on simple cases. Because of that, we have been able to do more and more difficult cases. I'll show a case later. But no question. Now, I would say at MCC, we always say, yes, sure. Actually, now everyone laugh at it because even our colleagues, oncologists say, no, we're going to say yes. When surgeons say no way, we're going to say yes, of course, no problem. Actually, we are a nightmare for radiation oncologists. Like, there's no lesion now we feel we can do. We have been very aggressive with very complex dissection and stuff. So for us in our practice, there's no question we have made a big jump. But again, I would say we are coming a little bit behind. But thanks to Epion, we have been, I think, doing quite a jump, nice jump, and now we are catching up with you guys overall.
Thank you. Dr. Berman, you and your group presented your experience with Epion this year at SIR, and it was one of the abstracts of the year. Congratulations on that. And can you briefly talk to us about your abstract?
Of course, and thank you. It was a really fascinating project, and I think it goes back to the question we asked previously to Dr. Arslan, which is why did we do this whole project? So what we ended up doing was every single patient we treated with the Epion robot, we collected exact timestamps as we were doing the case. The CT technologist was writing this all down. When we started the case, when we did our first control scan, when we did our first needle placement, how long did the planning take? How long did the ablation take? And we measured all of this time frame and how successful were we? How much deviation did we have with the needle? And did we get the ablation margins that we were anticipating? The whole reason we created this prospective registry was to go back to our leadership and say, we need this robot, right? You think it's adding all of this time complexity, you think it's doing all of this or that, but this is actually the truth. So we wanted to quantify it in numbers that we go to our administration and say, we need this robot. So what we ended up showing is that in the very beginning, comparing how the needles were placed and how long it took some time, right? You have to get used to, again, thinking in three different dimensions and figuring out how you want your needle to start, where you want your needle to end, which is a little bit different than how we usually think. But we showed that after about 10 to 20 needle placements and 10 to 20 procedures, the time goes dramatically down. And not only does it start to go down, it continues to go down throughout your experience. So we looked at our first 40 patients in about 60 needle positions. And you can see right around 20 patients, 20 needles, the time just goes down and continues to go down to the point where, something that might have taken 20 or 30 minutes before is now done in about 5 minutes. Once you gain more experience. And so the beauty of this project was that we prospectively collected this data. So we have exact timestamps that really shows to your administration, this does get a lot faster the more experience you get. And it's actually quite quick. This is 20 procedures, not amongst all of the, not amongst each attending. This is 20 procedures in general, because a lot of the work is actually on the technologist side, learning how to set up, learning how to put the 3D radio markers and stuff like that. And as long as you have the same text, they gain that experience too. And so that project really quantified it that you can then show to your administrators that it doesn't add additional time.
Now that's great points, and we've seen similar changes in our practice too. And for any technology, including this, I totally agree with you. Data, prospective data, all of this from different institutions showing the benefits is what would make a huge difference with people who are considering this technology. Poland, in your practice, I mean, you're relatively new to using robotics. Have you noticed a change or decrease in the number of check scans that you would typically do when you're doing image-guided ablations with CT?
Yeah, I mean, we did all of our ablations with CT. We had ultrasound in the room. Every now and then it would be a chip shot, and we would do ultrasound, but majority were kind of like not as skilled as our European colleagues in ultrasound. So majority goes to CT. And so with this, as we started, I can tell you between my first two cases, there was a difference. The second case was a little bit more complicated, but it went quicker with the robot. I can see the learning curve is going to be really quick. It's not essentially much of a learning curve for a physician's skill. It is setup, and then your techs, your nurses, the room kind of gets comfortable. They're ahead of and then we have excellent support in our area from Quantum. And with all that, it's become kind of I don't know what the right word. It wasn't cumbersome, but it's become very efficient already. And we're kind of at the fifth case or so, unlike other centers who has done a lot more. And so I think it already helped a lot. And then we're doing the more complex cases, not the easy ones as they recommended. So our quantum people were kind of, oh, are you doing this case as the first case? Like they were a little bit kind of concerned, but it did go well. And then I can see us doing regular cases, easier cases on a regular basis like you do. I believe you have a room that you do two, three, four cases just steadily with the robot. And that's my plan too. I'm going to have certain days that we're just going to set up like cases to be done in that room, and then hopefully 3 to 5 cases in a day. Let it be a couple biopsies, couple ablations, and then kind of make it even more efficient. That's the trajectory that we are going.
Our hope was to get to 4, but after introduction of Epion, we are now able to do 2. We were restricted to 1 before, but now we're able to do 2 cases, which is a big jump and has helped quite a bit with our patient backlog. Dr. Berman, in the US, your practice is very renowned for MSK interventions, and I understand your practice and Dr. Tutton and your other colleagues have been using it in MSK applications. Can you talk to us about that?
Yeah. So even with all of the advanced imaging, techniques like we have, like iGuide and other helpful techniques to use with your fluoroscopy, sometimes getting needles, particularly with kind of the screw fixation and cementoplasty, can be very difficult to get hard angles with fluoroscopy. Particularly anyone who's done a pelvic fixation before, there's always one angle that is really difficult to get your straight down the barrel view with the fluoroscopy unit in order to place your needle, and it's very challenging. The robot, on the other hand, has no issues with that, right? Because you do a cone beam CT, it's able to fuse all of the angles. You don't have to have the live fluoroscopy in order to see where your angle is. So particular corridors and pelvic fixations to be way easier to use the robot for, because it's able to do the weird angles that maybe a fluoroscopy unit can't do. The other area that we've looked at was in the spine and multi-level vertebral procedures, kyphoplasty, for instance. And once you do one CT, you're able to line up multiple needles and place them all at the same time. So I personally, in my practice, don't do a lot of kyphoplasty, but as an experiment, we did a cadaver workshop where they had people who had no experience realistically in spine interventions go in and do multi-level kyphoplasties, and I was able to place 4 vertebral bodies in less than 2 minutes.
Oh,
And so that's as a non experienced spine user, right? So this is going back to the residents, I'm functionally a resident when it comes to spine intervention. And even I was able to do that in 2 minutes.
no, that's great. I think those are very important points, and I feel like with the EpiBone study, the use of robotic technology in MSK applications is only going to increase. Laurent, do you feel that there are any challenges that can be expected for a new person using robotic technology, and what are some of the tips you have for them to overcome it? I mean, it's more of a general question, but if there's something specific that you would like to address.
Yeah, I mean, it's interesting. I was hearing Dr. Arslan talking about, how quick he was to get great results. I mean, I'm sure he's fantastic in terms of doing ablation already, but we went through a lot of phases. Actually, I would say the Epion, and I'm sure Thierry will agree with me, the Epion we have today is nowhere the Epion we had at the beginning. Like we had no axial mode, everything, like it was not that precise. And so what we learned though from that being very expensive, like at my institution, we are close now to the 250 case mark. So we have done quite a lot of those cases. So I think we know quite well now, what could be an issue for people. And I would say one of the key thing is to think it's too easy. That's the way I would look at it, and to be too quick on some key steps. And I think we already covered them. One of them, for example, is just when you do your planning, you have to really think that some stuff are going to deviate your needle. As Thierry was saying, the problem with the robot is that it's working on a fixed condition. It's not able to kind of move around your needles the way you would do with ultrasound when you would just torque and everything. Here you will go to a straight line. So what this means, for example, is be careful with the ribs. Go right in the middle. Don't go too close to a rib. You won't be able to adjust. And everything is Thales law. Sorry for bringing some simple math there. But if you get a tiny angle at the beginning, remember it's going to be a very large distance at the end when you have your target, especially when it's deep. So that's one thing you have to be careful. The other thing is really use axial mode. Again, at the beginning, we didn't have it, so we would insert the needle very far from the skin. So again, you will get a tiny deviation that would lead to a very large distance. And those will really be the main thing. And that's why I think there's this idea of learning curve. Be comfortable with single needles, and you move to more and more complex ones as you move. But really remember, again, that would be my big advice for someone starting. Remember that it works on fixed conditions. So if everything moves, work very hard, for example, with your anesthesiologist. Nothing should move between your acquisition and when you do the ablation. As soon as it moves, then you're lost and you won't be on trajectory. So take those small steps, work well with your team. And then I agree, as soon as you do that, then you can just insert the needle one shot and then it's going to be really fine.
Those are excellent points that you brought about. And axial mode, to me, especially with IRE, was something that was a game changer. For those of you not familiar with it, when the robot sets you up for the needle placement, and if it's far away from the body, you have an option called axial mode where you can bring the arm as close as possible to the body, start with the needle placement, and once you get it into the organ, then you release the clasp and bring it back, and it will stop exactly at the depth that you need to be at. And then now you're able to push the needle with one push, thereby limiting or minimizing the problem that you could have with deviation. So those are excellent points. Switching to margin confirmation, again, a topic that's very important in ablation today, the importance of getting a good margin. So, are you all using the ablation confirmation routinely in your practice? I'll start with Dr. DeBer. How about Gustav Rusi? Do you use this routinely now?
Well, we should. We don't. I have to be honest. We are still believing that we place your needle, you're correctly located, you're going to get your margin. We do that when we already have some doubt, but we should be more. It should be done on a routine practice. And my only concern is that when you do liver, you're going to inject the people once for seeing your target, and you're going to inject again the people. So it's a lot of contrast medium. I'm always afraid about those kidneys. I've done quite a bunch of cases with arterial CT enhancement of the liver. So we place a catheter on the hepatic artery. It's kind of routine basis or very, very common in our practice. In this case, I'm doing margin confirmation with the software because I don't care about injecting 10 more cc's of contrast. So my mixed feeling is, yes, it is useful. Yes, you should be careful about the renal function of those patients. But always when I have a catheter in the hepatic artery, and not always when I have to inject IV contrast medium.
Lauren, are you using it routinely to confirm, or in most cases?
So we didn't, at the beginning we were really focusing on everything else, and we are still happy looking at our console and everything, and so confident. Actually, we look at our cases. We looked back. I think we should have done that. So now we are really working on getting it in the workflow, but it's not always easy actually. And it's something I'm trying to fix in terms of institutional, impressions that people feel that we always do 2 CT scan anyway. So we inject, I agree with Thierry, but the contrast, we are careful. Sometimes we decrease the dose for the second one to get something a little bit okay for patients. But so we look at confirmation. But the problem is that there's such pressure for everyone for the case to be done. This idea that this is the end, this CT means this is the end. So I'm pushing hard now to say, no, this is a critical time of the procedure. It's as important as everything we did before. But I agree, I think there has been some adjustment now, and the system should be a bit quicker as well for segmentation. Because in the version we had was not that fast, so we could not really doing streamline, but now it's getting better. So now definitely something we know we need to do it. And having looked at our results, I think you can no longer think that you're okay if you just look by eyes. We know that from literature even outside Epion.
No, we were guilty of the same thing when we started out with the new technology. You're more focused on the technical aspects of it, but we've definitely moved in the direction of now doing it routinely for cases, especially in the liver. We do a pre, post, and then do the overlay.
Yeah, as I was mentioning earlier on, it's just getting all your team. It's not just yourself here. It's just your team, your nurses, your radiographers. We call them radiographers. You call them techs up there. All of them, and also your anesthetist to sort of adapt to the new process of having an apnea and then switching on the ventilation and then the apnea and things like that. So all of that is a bit of a challenge. We don't have the same anesthetist all the time, so we have different anesthetists coming and going, and so everybody has got to get used to where the anesthetic machine is and the apnea of sort of going in and going out of the room, and turning the apnea on, turning the ventilator on and off. So when we do the scans, etc. So that's one challenge, and also with the radiographers as well, with our technicians, just to ensure that they are familiar with the process as well. That can be a problem because we don't always have the same tech. There can be different techs on different days, and so that can be a challenge to get all of them trained and to ensure that they are familiar with setting up the the machine and the layout of the machine, etc. So those are the challenges. So and we also have a larger team. So we are about 7 of us who do liver ablations, and we've got another 5 who do renal ablations. So getting all of them, so doing a list means it takes longer. There's a lot more of you to need to train. So my ablation may come every other week or every second week. So there is an element of you need a lot of continuity with this. You need to do back-to-back ablations at least on a 3 to 4 weeks so that you get really familiar with the system. So yeah, those are the challenges, I have to say. So in a big unit like ours, that's been a challenge to get not only just the techs, the anesthetists and ourselves sort of get familiar with the system and do it independently. Yeah.
Great. For the benefit of our viewers, I would like to see if all of you or some of you have any interesting cases that you would like to share. And if you have, we would probably have time for one case. Laurent, would you like to go first? Do you have a case to share?
As I said before, like we were not that savvy, with complex ablation. Again, diverse practice, a lot of ultrasound guidance. So some areas were not very natural for us to do. But just to show you a case that we did now a couple of months ago, we had a very large neuroendocrine practice in our institution because we're one of the European center, doing neuroendocrine tumor. And this is a patient. She's 50 years old. She's closer to 60 years old. And she had this single lesion, oligoprogressive lesion here at the left renal item that you could see here on the axial CT scan with the contrast. And this is like a 3D reformat of this mass. So the entire thing here, you see the mass, and this is actually the renal artery going into the lesion. So if you look at this lesion, the renal artery is going right through it, and the renal vein is going right in front of it. So technically before Epion, we would have said there's nothing to do. This case was this is the MCC, and the urologist say there's no way I could do, like another dissection without sacrificing the kidney. And the idea in this patient was to make sure that we will keep the kidney on. And I just want to show you what we could do now with complex IRE thanks to the Epion system. So you start by doing your planning scan. You can then start to do a multi-needle kind of planning. In this case, I divided the lesion in 2 areas, the superior one, the inferior one. So superior one with 5 needles. And now what you could do is actually insert your needle, and then you can do a CT scan with all needles inserted. So I inserted all of them sequentially, 5 needles, no control in between, just 5 needles, and then I control. And then what you do when you're in place, what you could do is actually you can measure accuracy for each needle. As you can see, some of them were 1 millimeter, some of them 2 millimeter off, which was actually pretty good considering the very difficult location here. Same thing for other needles. And something which has been incredibly useful now is this piece of software, which will actually give you the in-between needle relative placement in terms of spacing, in terms of also parallelism and also depth. So this is very useful because you can know if you are or not within your constraint for IRE. As you know, IRE has a lot of constraint. And in this case, it was just fine. It's just to show an image of the pre and post scan here. So 2 needles of IRE placed here, and you could see the lesion enhancing at the top and then gone at the end. So did the same thing, axial plane. You can see how the lesion disappeared. This is on the same day. And then just to show you the whole lesion as we decrease. Did the same thing for the lower area, had to do some hydrodissection because bowel was in front. And then again, like in this case, total of 9 needles of IRE with hydrodissection. And in the end, the patient is, there's a tiny, we did some imaging, and there's a tiny kind of a spot which will just follow in this patient in the future, but almost nothing remaining despite an incredibly difficult location and nothing else to offer to this patient. So just to show you how you can go to, I would say, practice with not such a huge experience to very difficult cases thanks to a system like Epion, even for very complex procedure like IRE.
That's a great case, and the feature that you showed for IRE users is coming very useful and handy for us. You can check the depth, the parallelism of all your needles with a single click. In the past, you would have to scroll up and down, and I think that's a big benefit. Terry, do you have a case to share?
Yeah, I can share with you 2 bone cases, and clearly then we will be able to see how we can use the system with a very sharp angle in the z-axis. Just confirm me that you can see my screen. Are you good?
Yes, we can see it.
So you can see I've been placing some iliac screws that have been placed under robotic guidance, but I will not go into detail in those screw and sematoplasty. But now we want to place a screw for the ischemic axis. So the ischemic axis is really going up high in the z-axis. So the patient has been placed prone, and then we're going to send the robot to the ischemic axis, and you will see how sharp is the angle to the ischemic axis, because you have to enter in such a direction that, of course, you cannot use cone beam CT bull eyes. So this is clearly what we want to insert as a screw. And the next step is to just insert the spine with the robot. Nowadays, we are using needle. That was the early days, so we just make marks on those pines, but it's, of course, totally off-label use. And see how it looks like. And this is what you can get the result. So that's clearly very difficult to do under cone beam CT. That's very difficult to do under CT guidance. It's come, I will say, like any other trajectory if you use the robotic navigation with Apian. And you can see here the final result. We have really nicely in the ischemic direction to reach the bone. And then, of course, to place the screw and the end of the procedure. So I think it has been highlighted by other speakers. But when it goes to pelvic reconstruction, pelvic osteosynthesis, even pelvic ablation with IRE or electrochemotherapy, it's kind of very interesting way to use it. And if I may kind of use to see this case as well, I just want to illustrate it, the new workflow with a robotic device. So this is a trans-iliac fixation to go to the sacrum. And if you look to the upper left of the slide, you can see that the needle is slightly off target. There is the trajectory in purple, and the needle has some angles. So now what we want to do is to readjust the trajectory. Just see that the needle has just passed the cortical bone. The trick is to enter like a few millimeters in the cortical bone. Then you can still move the needle and change the angles. So we are bringing back the robot close to the needle. So we are bringing back the robot close to the needle. Then you go in this mode, action mode. Then you can place the needle inside of it. And you can redirect the trajectory. So if you have a slight deviation when you enter the cortical bone, you can still correct it. And you have the result you can see on the bottom left where you are perfectly aligned with the needle. So in working in bone, the workflow is slightly different. You have to learn about it. And that's, as we discussed, the beauty of going to the bench top before and being able to go to clinical practice. And this is the final outcome of the cement and the needle which have been placed. So demonstrated that you can use it in bone, you can use it in difficult angles. And the recatch system that we use in probably 50% of our cases is very important. And what we report in the animal experiment that the deviation was with a mean of 2.1 millimeter. Thanks.
Great cases, Terry. Thank you so much for sharing. We can start again with Terry. Where do you think this evolution of using robotics in ablation is going to evolve as we move forward?
Well, I think that's as Laurent mentions, the robotic we had 1 year, 18 months, 2 years ago is already different to the robotic we have today, because small progress, action modes, recatch, and other stuff make it different. So I think it's a permanent curve of improving, and we are all part of it. And I think that's very important. And the robotic from today is better than the robotic from 18 months ago. So I think that's a very important point. The second point is one of the beauty of robotic, it's that it's ablation device agnostic. So we have seen cases of bone, we have seen cases of microwave. And that's very important because if you think about it, if I think about my practice, the number of cases we are doing with a single needle is decreasing because there is IRE, because there is electrochemotherapy, because there is cryoablation. And discussing about time and how much we gain time or we lose time. I think that the common feeling of all speakers today is that as far as you have multiple needle placements, you very likely gain time because the way you have to plan your trajectory is super smart. I mean, the way you draw a line in the center of the tumor, you choose your number of needle, and planning 5 needle trajectory is as fast as planning 1 needle trajectory or very close. And then it's go to needle insertion, and needle insertion of 1 needle is a few seconds. Needle insertion of 5 needle is a few minutes. So I think that's for multiple needle ablation, I have no doubt that you are getting time, you are getting accuracy, you are more parallel. So in essence, there is a lot of to do with the robotics. For easier case, I think if you think about our trainees, they will be used with robotic with complex cases, and they will use robotic for easy cases as well. And I want to mention something that nobody says. It's irradiation to the physicians, because we all have been working in X-ray all our life. We just think it's normal. It's not normal at all. And I think the best way, I had to buy this robot with a guy from the administration, because honestly, explaining ablation margin to my administration people is kind of complex. Telling them there is a way that Dr. Deberg can have no irradiation versus if I don't know the robot, I will get irradiation, is a very strong and powerful convincing device, because this guy cannot argue that you have to be irradiated.
No, thank you, Thierry. Great insights, and thank you for the pioneering work you did in this space. Bulent, where do you see this going down in the future, and how do you see this evolving?
First, I'd like to thank Thierry and also you for getting us involved with it and then making this technology available. I think, in the end, money goes with the inflation. Time you can't buy. This is a technology that saves time, that increases efficiency and improves safety. I see this exploding in the 5, 10 years. Any institution that has the potential and then they are busy enough, they want to save time, they want to improve safety and then become more efficient. This is going to be everywhere. It's not just going to be like, I don't know how many right now, 10 institutions. It'll be the standard in 10 years, in my mind. So the early adapters will benefit more. The late adapters will kind of regret and be left out of the kind of curve. That's where I see this happening. Just like with any new technology, very technology-based specialty, if you don't believe in it, it just doesn't work.
Absolutely. Laurent, what do you think?
Yeah, I think something where I see a lot of improvement will be in the whole planning and AI. I think that's gonna be the next big step. Again, the Appian is not just the robotic arm and inserting needle; it's all the planning. And I think AI here will help a lot with proposal, for example, which will even speed up even more. For very complex cases. So like you will start not just with everything you have to design, but something I will tell you, okay, I think this is the way you could do it, maybe with 2 or 3 proposals, and you choose. That I am sure, I mean, in my mind, and I know there's a lot of work in that direction, I think that would really speed up the processes.
Thank you. Thank you.
Yeah, no, I agree with all the comments that have been made. I think one area, perhaps, a robot is here to stay. That's for sure. I'm convinced about that, and I'm convinced that I think in future, at least in all the major institutes, you would see a robot playing a significant part, if not the whole part of all the ablation practice. That's to show. I think in future there are lots. We'll see a lot more changes. I'm sure the robot will be much more streamlined. You will have it'll take much more smaller footprint. It may even be integrated with the CT scanner, where you will have one screen where you see the CT images and the planning images, and also the planning aspect of the robot. So I think there's a lot that will happen. I think in the next 5 years, the robot is here to stay, and I'm sure we'll see a much more advanced, much more smaller footprinted robot that we will see in the years to come. Like we saw with all our ultrasound machines and our microwave machines, they became smaller and smaller as we went on. So, and I'm sure robot will become an integral part of our ablation practice in the years to come. Yeah.
I couldn't agree more. Thank you all again for joining. This has been a great conversation. and exciting to be on this journey with all of you. And hope to see you all in person soon. Thank you. Take care.